Are you wearing the lapel?
I'm not. I'll stand there.
Okay.
Or take my wandering light.
Oops. Good afternoon, everyone. We have just about 4 o'clock, and are we on the air, Phil? Very good. Thank you. Thank you. Well, welcome to our May Health Services Forum. We have a few topics to go over today. The first is a hearing from Sean Lyons, who is with Dispatch Health. It's in collaboration with the Cleveland Clinic for their hospital home model of care. We'll also review your options for physician provider coverage within the Stevens Care Center, a few other minor announcements, and then we'll end with Georgia Newman, our medical director, with Q&A. So I'm going to have Seth Walensky, our CEO, introduce Sean Lyons.
Okay, good afternoon, everybody. I want to introduce you to a friend and colleague of mine, Sean Lyons. Sean is the Director of Mobile Integrated Health at Dispatch Health, which is a company that in some form or fashion we worked together. And so Sean and I worked together for 2 years. Sean is you're going to hear about the Cleveland Clinic's Hospital Care at Home program, which is a Cleveland Clinic program that is partnered with this company called Dispatch Health. Sean got his degree from Hiram College, so he's a local folks, and has been an EMT and community paramedic for many, many years. Also worked directly at the Cleveland Clinic running their mobile integrated health program before coming into the hospital care at home environment. And Sean and I, as I said, worked together for 2 years. We traveled around the country developing programs like you're going to learn about here. We worked at the Mayo Clinic in Jacksonville and Arizona and Wisconsin, in Boston, at Yale New Haven Hospital in Connecticut. And Sean as really a leader in the field when it comes to taking care of acutely ill patients in their home. And I think you're going to enjoy hearing all about the program that's coming, that is now in the west side of Cleveland and into Lorain County. So without further ado, here's Sean.
Thanks. Hi, everybody. Who here has heard of Hospital at Home? A couple of people. Seth. You don't count. Great. So I really want to give a kind of an overview of what that type of care looks like. And I brought some equipment and the technology stack that we actually bring into the home so that everybody can kind of get the feel of what it would be like to be a patient in a program like this. We're a little echoey. So we'll get into that. I have just some overview slides we'll go through. Definitely want to spend a lot of time doing Q&A and really, answering any questions that people have from the perspective of, that kind of patient experience. So Hospital at Home, our company, formerly Medically Home and now with Dispatch Health, has really been doing this for quite a while. Started back in 2012. Really, these programs kind of blew up during COVID, where a lot of patients wanted to stay at home, and there was more kind of emphasis on that, but also through a CMS waiver that allowed these programs to operate like a hospital. So a patient could go into the hospital, could go into the ER, get admitted, and from there go home. But kind of on paper, right, in terms of the payer agreements and through CMS, you're admitted to Cleveland Clinic Hospital in this model. You're just receiving your care at home. And I'll go into a little bit more detail about that, but I want to kind of level set there that we call it hospital alternative care, or HAC, and you may see that on a couple of these slides. But that's what we're talking about, is we provide all essentially the same services that you would expect to have in a hospital. That includes meals, that includes, therapy and other services outside of just the clinician going into the home. But in this case, with Cleveland Clinic, you're still being cared for by a Cleveland Clinic physician and Cleveland Clinic nursing out of their virtual command center in South Florida. So Cleveland Clinic runs kind of a big virtual command center down there that touches patients all over the state of Florida and also now here in Ohio. So they are part of Cleveland Clinic. Those physicians are actually located down in Florida, and they're working with whatever physician that you might have been admitted to at Avon or Fairview Hospital. So, the idea for Hospital at Home, is really that we want to provide a better experience and better care while also having you at home in a more comfortable environment, and I think a better environment for healing ultimately. We value the time that you get to sleep, right? We're not going to draw labs at 4 in the morning. Maybe we'll wait until 8 to come in the morning and see you. There's not all the beeping and lights and all the crazy, chaos that comes with being in an inpatient hospital stay. And also, I think there's a lot of value in just kind of building and developing habits like taking your medication or following your plan of care at home, at your kitchen table or in your living room. And so those things, kind of extend beyond the discharge from the hospital. Instead of there being that event where you get brought home at the end of your hospital stay and transitioned, really it's just we have services there for you as long as you need them. When the care team, the physician believes that you are stable and can be discharged from the hospital, just like if you were in brick and mortar, we would discharge you from the program, but really we're able to kind of transition you more kind of gently back into a care setting because you've already been there. So that's kind of the idea here, is to bring potentially lots of people into your home for a period of time. The average is 3 to 4 days for a Cleveland Clinic's program where you're actually acutely admitted. And that would include paramedics like myself, potentially nurses, maybe a specialty nurse like a wound care certified nurse, physical therapy, occupational therapy, things that the physician orders as part of your care plan. We have mobile radiology. We could bring in and do an x-ray in the home. Haven't quite got the mobile CT scan set up yet, but we can do some other things like ultrasound. And then the paramedic in this role has a lot of tools, which I'll go over, that are sitting on the table here, where we can do a lot of things in the home, like point of care lab testing, ultrasound, EKGs, things like that. So we're able to really bring most of the stuff that would go in a hospital room, IV pumps, all the equipment, right into the house. And so a lot of this equipment would kind of be set up, potentially in your living room for the course of that stay. So again, a key reason I think why patients choose the model is for comfort. I think there's another component of this which is really fascinating to me, that this model really promotes not only the patient, but the patient's caregiver being, acutely aware of the care plan and also involved in it. You have to be involved in your care in this environment where you are still being guided by virtual nurses or the in-home visits with the paramedics, but you're still kind of taking medications on your own. You're going through the process of, being aware of all the orders that are in and the schedule for the day and what things look like. You have much more visibility into what the care plan is because of that dialogue that you're having throughout the day with your nurse and the in-home providers, as well as the virtual physician, consults that come in a couple of the days at least while you're there. So you get the opportunity to really be kind of immersed in your care planning and involved and aware, but you also have that there's the common disconnect in healthcare around actually listening to patients, and that comes through providers being really busy. Harvard released a study a few years ago that I reference a lot that was, I think it took 17 seconds on average for a physician to listen to a patient without interrupting. They listen to patients for about 17 seconds, and that's because they're under tremendous pressure to see so many patients per day, and they have a lot of things going on. But in our environment, you still may not, spend an hour talking to your physician, but the paramedic's going to sit on your couch with you for the hour while you're doing your infusion. You're going to have lots of opportunities to talk to the virtual nurse throughout the day, and so you have way more time one-on-one to actually dialogue with the care team. Pets, we have some horror stories out of South Florida, I will tell you. But no, that's another really, really good reason for the program. We had a patient that I think about. It was in one of our markets in Idaho that was desperate to go home because they had horses and no one else could care for them. It's like, well, we'd prefer that you kind of take it easy, while you're admitted to the hospital, but they were out there with their IV pump in a backpack taking care of their animals. So that's certainly, it's a factor. We definitely, if you have pets, the clinician that's coming into the home may ask that the dog is put in another room or something, just so, they're not knocking over a sterile field if we're doing some sort of procedure. But in general, I think it's, best to reduce the stress that a patient is under as much as possible, and being away from your pets, your family members, is a big part of that. So again, I've covered a few of these things, just kind of walking through it. So you have the virtual physician, so a physician in a cubicle sitting behind a camera at Cleveland Clinic is going to have some scheduled touch points with you throughout your hospital stay, but also could be brought in at any time. So if the nurse is having an issue or the paramedic in the home is having an issue that they want to bring a physician into, or if you have a question for a physician and ask to talk to them, they can bring in a physician consult or an advanced practice provider. So a PA or a nurse practitioner is also available. So you're going to see that your provider very frequently on the tablet that I have sitting over here. And then the virtual nursing care team, and this is in that kind of first bucket of hospital team, the Cleveland Clinic nurse that's assigned to you as your nurse, you're going to see them throughout the day, almost continuously, right? So there's periods of time, and they'll schedule these visits, so morning meds, afternoon meds, vital signs, things like that. The nurse will come on video and kind of walk you through doing those steps. You are able to take, your own vitals and perform some of your own kind of assessment in the home and in partnership with the care team that's virtually. And then when the in-home providers are there, they're on video, throughout that visit as well. So I actually went out and ran a visit this morning for one of our teams, and there was a wound that the physician wanted to look at, so I was, holding up the tablet and doing the kind of in-person assessment. I think in general, it's safe to say that with the advancement of technology, virtual care is a large part of the future of healthcare. But I think what's really important is tethering it and partnering with an in-home, like in-person clinician. And I think that, paramedic falls into that category of a really kind of specialized in-home care provider. This is something, we started, Seth mentioned, I worked at Cleveland Clinic previously, and we called it paramedic assisted virtual care, where we're sending someone into the home that's providing that like human interaction, the physical assessment, the hands-on care, while potentially partnering with a specialist or a physician to kind of help with that assessment and write orders and things. And so I think this program really kind of brings those aspects together, where you have a large group of people involved in caring for you as a patient. Some of them are in person, some of them are virtual, but they're all part of the same team and they're all talking to each other. So I will say the mobile command center, one thing I wanted to mention, it is 24/7. So you have a nurse, one click of the button on the tablet will get a video with the nurse 24/7. We have scheduled visits, and a medic isn't just going to show up unannounced. You'll be able to see your schedule, but you will have access to a clinician 24/7. The whole time you're in the program, you can one click, a nurse will come on video. Probably it's your nurse. Our system routes it to your assigned nurse. If they happen to be on with another patient, you may get routed to another nurse, but it's all part of that same team. And so you have that kind of constant access to care. If there's an escalation or just a simple question, you can reach out to anyone at any time. And then ideally, it's around 2 to 2.5 kind of on average visits per day of an in-home clinician. So you're going to be seen kind of in the morning and in the evening, but then multiple virtual touch points throughout the day and the evening as well. So talking through kind of who's eligible, I knew that's a question I'm going to get, I'm sure, at the end of this, so I wanted to take a stab at it. There are certain diagnoses that are the most common, CHF, COPD, pneumonia, kidney infection, skin infections like cellulitis are a common one. And so there are multiple kind of types of admissions or types of diagnosis that could funnel into this program. Just because you have a certain diagnosis doesn't necessarily mean you're eligible. There's a couple of other factors. One is kind of environment. We do a small like home safety evaluation. I'm sure that isn't an issue in this room, but we have to ask questions like, do you have electricity? Do you have, a refrigerator if we need to, refrigerate medications or something? And so there are some screening questions that you would get that are along those lines. And then, obviously payer is a question. The Cleveland Clinic, I'm not going to go through the whole list. It's ever evolving, but they have some commercial payer contracts and obviously take CMS patients as well. So pretty much, a wide kind of catchment of patients. And there's a in-person physician and nurse practitioner team in Cleveland Clinic here at Avon and Fairview that actually go through that kind of hands-on process of admitting patients. And so if you were in the hospital, if you were in the ER at Avon, and you happen to mention this program, you're probably already flagged in their system in Epic, whether you're eligible or not through some various criteria. So you can certainly bring it up. I'm going to encourage you to do that, but there are some screening steps that they would go through, and if you were eligible for it, you may get admitted directly out of the ER, and we would transport you home before you even went upstairs onto a floor, or sometimes they'll keep a patient for like a day if they're pending some results to various tests or things. And so, it's not uncommon for us to bring home patients kind of the next morning as well. And geography, obviously, you live here, so you're in the coverage area. With our contract with Cleveland Clinic, we have a radius of about 25 miles around each of the hospitals. That's kind of a CMS guideline thing. That's why it's the specific 25 miles, but there's a list of zip codes, and this is one of them. So this is technically within the area for Avon. One thing, I won't read this entire slide, but I just wanted to say there is no out-of-pocket expense for the program. It's the same as if you were admitted. So if you're admitted at Avon, you're admitted at Avon. If that's their virtual floor or the 5th floor, it doesn't matter. So that's a question that I get a lot, and I wanted to kind of lead with that no, you're going to see a lot of additional services, the meals, all the stuff being brought into the home. You're not being billed for those things any differently than a normal admission. All right, so what comes into the home? I will actually take this. So I want to walk through the tech stack that actually would come into the house. So you have 3 options for reaching out to your care team. So you're going to wear a normal kind of fall PERS device. You might be familiar with these. This is just a speakerphone, and it's routed to your nurse in the command center, right to their headset. If you hit help or if you hit the button, it's just a speakerphone directly to your nurse. It's not calling 911 or anything. That's just one of our options to make sure that you have a way to reach out to your care team. Oh, the PERS device, yeah. Yep, so it's just your kind of a normal fall alert device, but in this case, it's routed to our phone system. The other option is just a Wi-Fi phone. So this is something that we would set up in the house. It's a normal looking kind of office phone, but if you lift the receiver, it automatically calls your nurse in the command center right to their headset. So you don't have to type anything. You're not punching in a number 24/7. You could just pick this up and it rings directly to your care team. And then the other option, and I referenced the tablet a few times. This is what that looks like. If you were admitted, you would have some scheduled visits there. I have a photo of that in the slides later. But this button down here is the key. That's Talk to My Team. That just starts a virtual visit. So it just opens essentially like a Zoom video call directly to your nurse in the command center with one touch. So you hit that, it's going to bring them up. They can also call you on the tablet. So if there's a question that they have, or if it's time to do vitals or your med rounding maybe in the morning, they would ring in. It does chime multiple times before it just turns the video on, so it's not going to catch you off guard. But that's a way that you're primarily communicating with the team. And then, like I said, you're also seeing your schedule. This is one of those key benefits to hospital at home. Lab draw is at 8:30 in the morning. My nurse is coming, paramedic is coming at 9. Our PT is coming at 11. When you're in a hospital room, you have no idea when anything's happening. People just, pull the curtain and walk in at, random times. They may try to tell you when things are happening, but stuff changes all the time, right? But because we're in the field and we're actually physically driving between houses, we have a pretty good idea of when our ETAs are. And so we're able to share that with you. So you actually kind of know what to expect going into the day. So that's the key components here. Our team also utilizes there's a blood pressure cuff right here, and then there's a weight scale and a pulse ox that all Bluetooth connect to the tablet and then are automatically integrated to the hospital's EHR or like Epic. So your chart gets those vital signs in real time. So if you're in your house, you're feeling a little short of breath, you put the pulse ox on, it reads it, it alerts the nurse that it was read, and your vital sign is already uploaded into your chart. So everybody's able to see that in real time, and you're able to do the vitals, on your own or with the in-home clinician. So that's the stuff that gets left in the house for you. Aside from that, we leave some boxes of generic kind of medical supplies, blood tubes, things like that. You're not expected to use those. We don't make our patients draw their own blood, but we leave it there for the clinicians that are coming and going. So expect there to be a few other boxes and things laying around, but we try to keep it organized and clean. We just have to leave, some supplies, just like a hospital might have a crash cart. We have to leave some stuff in the house. Sorry. The primary in-home clinician or the paramedic brings in a bunch of other equipment. And so just out of this backpack, I brought out a few things to show you. This is a point-of-care ultrasound device. We use this for various assessments and or starting IVs. We're able to do that in the home. We have a blood analyzer. This takes 2 minutes to give you a full metabolic panel. So a lot of your lab work can be done in the house, a few drops of blood. So that's something that the team uses. We have an INR device as well. If somebody is on Coumadin, we're able to do those checks. It's a finger prick. It doesn't take a whole blood draw. And then also it's our little version of, the normal kind of hospital infusion pump. So infusion pump on a little pole is going to be left probably, in your living room or your bedroom. And we're giving, a lot of IV antibiotics or fluids. That's going to be left in your house as well. The medic also brings in a pharmacy. So we have about 78 medications that our team is able to carry in case we need them. Other medications are actually delivered from, in this case, Avon Pharmacy. So you're going to get a big bag with a bunch of infusion medications and oral medications. The medic will actually sort all that out for you, so you know which your oral meds are morning to take or evening. The virtual nurse will walk you through all of those meds, but the medic actually carries a little pharmacy also, so that if you need something that isn't ordered, maybe like a pain medication or additional fluids or an antibiotic, if you're changing your care plan, the medic is able to do that in real time. We don't have to wait for a courier, and we're able to do it right there in the house. So that's kind of the tool stack that the medic brings, and then the technology stack that is left in the house with each patient. All right, so we talked about this a little bit, but again, just kind of what's a day in the life actually look like? It's you wake up in the morning, you call your nurse, or they call you, and they go through those morning meds. They maybe have you take a set of vital signs. That's kind of virtual rounds. Then the care team kind of privately will all meet, so your physician and the nurses and everybody get together on a call to talk about what they're going to do for your care that day. And then the nurse will call you back, the primary and home clinician or the paramedic will come into the home, and they start, the daily visits. And so we're doing those in-home visits, typically 2 a day. If you have, an antibiotic that's 3 or 4 times a day, you may see more of us, but most people get once in the morning and once in the evening. Ongoing monitoring, again, we can do the vital signs and the virtual care throughout the day continuously. And in the evening, they do a kind of a tuck-in visit, they call it, where the nurse will call and just make sure that you're doing okay, you're ready, in the evening. You take your evening meds if you have some bedtime meds, and then they'll walk you through the schedule for the next day. So just be aware, our first visit is going to be at 9 tomorrow. This is what it's going to look like. They're able to kind of prep you for what the next day is going to be. Okay, so just talking through again, we have 24/7 virtual care. If something happens, we escalate through 911, just like if you were at home, without our care. But the virtual team will probably manage that for you. So if you have, a new symptom, if you have a concern, you would still call, talk to your team, but they may escalate, if needed. So if somebody needed to go back to the brick and mortar, we'll absolutely do that. If we need to take you back for the night to the hospital because of some situation, we could potentially do that. I will say that it's very rare in our programs that people actually get escalated back. It's a couple out of 100 potentially, and typically those are for things that we can no longer manage in the home. If you are on, for instance, continuous cardiac monitoring, that's not something that we're doing in the home. So if there's things like that it doesn't mean that you're necessarily more sick, but it's just something we don't offer. Potentially you may go back, but most of our patients are fine. Once they get home, they've been screened and they're fine to stay there. And so there is, a pathway for escalations if possible. I met with the local fire departments around this area, and when we went live with the program, so everybody's aware of what we're doing and how they could potentially be called on to be a part of it. But really, we kind of rely on our own teams and our own service providers in the network. So if you had to come home from the hospital in an ambulance because you had issues with ambulation or you were on an infusion medication at the time or something, we would coordinate all that. You're not being charged for the ambulance ride. Traditionally, our patients actually could come home with me or one of the paramedics in our SUV. We'd actually drive you home ourselves and get you set up here once we get back. So for the most part, once you're here, you're good to go. But there is, obviously the care team and the virtual clinicians that you're talking to throughout the day have the ability to escalate if something happened. I will click through this. I wanted to highlight this photo because I brought it up. That's what your schedule would look like. So you're able to just see very cleanly. It's a field service visit. So we're not going to give you an exact time that we're going to show up, but we're also not the power company, so we're not going to give you a 6-hour window. We'll just tell you, within 30 to 60 minutes, this is when we'd expect someone to arrive. So you'll see those windows there. And really, we try to be, through our system and the kind of logistics engine that runs all of this, we're able to get really good ETAs and monitor all of the comings and goings of all the clinicians that come into the house. I had a couple of patient stories here. I won't, just read them all for you, but I will say that the primary feedback that we get, obviously positive, dramatically so in terms of patient experience scores and the responses that we get from patients. We hear a lot of responses from patients' families as well. Because it's virtual and the physician consults are all virtual, it's really, really easy for us to just tap in a third party. So if someone lives in one location and maybe their daughter or their son lives out of state, we can actually just bring them into all the physician consults, and it's not a hassle because they're already happening virtually. So that's kind of a different kind of outcome of this, is that we're able to bring family members in potentially that are out of state really easily into the care, and it's a common thing that we do. So asking for that is not putting us out at all. This is something we do routinely, where we're able to just add someone's email to the link, and when the physician calls in, we're able to bring in another third party as well if we want to. This, I think I have another one here. Let's see. Yes, so I'll walk through this one. So this was just a simple kidney infection, escalated to the hospital actually due to pain. This was a couple weeks ago. Obviously, name has changed here, but we have someone who was fairly stable but needed multiple courses of infusion therapies that didn't necessarily have to happen in the hospital. So they were on, they needed labs multiple times a day. They needed their in-person assessments, and the IVs, therapy that we were giving them for their antibiotics was something that we could easily manage. And it was 3 times a day, but we were happy to do that and sent out a medic 3 times. So this patient was on census. I think I have it here, but it was, 5 days. It was a longer stay, but they were in a facility and similar to this. And we were just kind of coming and going and talking to there was a nurse there. And so we were kind of check in with them and explain what was going on, and kind of download with them what was happening, and just kind of got the patient right home. They were able to go, people, I think the first night someone brought them their meal, but the next day we were like, here's your IV pole. We'll walk it with you, and you can go out actually and sit and eat with everyone. And so, this was just a really great success story where patients, caregivers, who did live out of state, and the facility that they were at, were involved in the care planning and aware of what was going on. And it was a simple, fairly easy trajectory for the patient. Nothing that they were on was, terribly complicated, but they would have been, out of their house for those 5 days and were able to come right home out of the ER. A couple of just published findings I did want to say. We talk about patient experience over and over and over again, and one of the main things I think that matter to people are if you get hospitalized, if you have to go to the hospital, you don't want to go back. And so, for various things, this was specifically heart failure in Florida, published by Cleveland Clinic. They had a 30-day readmission rate of 17, roughly 16.9, and we brought it down to 12 with that patient population. So same patients, same basic set of symptoms and their diagnoses, and these heart failure patients were able to stay home after an admission for 30 days. More effectively than others. It was a fairly large group that they looked at. I forget if I have that here or not, but it was a few hundred, and that was over about 6 months last year. So they have, we have done about 90,000 admissions now, about 95,000 admissions to programs like this across the country. Cleveland Clinic just hit their 5,000 number. So this is new to Cleveland Clinic, Ohio, but something that Cleveland Clinic and the virtual care team has been doing for a long time. And patient satisfaction scores, I threw that up here because it was something that Cleveland Clinic published. 95% would highly likely, so the 5 out of 5, to have this program be recommended to a friend or family member. So I went through a lot of these things already. I think I'll move forward so we can get to some questions. I do have a couple of photos here just of what our vehicle looks like. One of them sitting out there, but we are, around this area. We have 5 paramedics on every day, and then a large group of nurses that we work with as well, kind of PRN. So we have, I think, 12 right now on census. So when we talk about a daily census, that's 5 patients at a time. Cleveland Clinic in Florida, they have about 38 today. And so if you think about it, for the virtual floor is a really big med-surg floor at a hospital, or almost 2 med-surg floors at a traditional hospital. So the thing is growing and scaling. We're really excited for what we're doing here in Ohio. We went live with 2 hospitals now. What we expect over the next year, we're going to pick up additional Cleveland Clinic hospitals and continue to scale that. So just wanted to throw that out there that, it's new, not new to Cleveland Clinic, not new to us, and we're really excited to bring it kind of home, for me at least, here to Northeast Ohio. Any questions? Yes. Yes. Grab the mic.
I was wondering if you could tell us what your average length of stay is for somebody admitted to the program?
Yeah, so nationally, it ranges from 3 to 5. Cleveland Clinic specifically is 3.8 is the average right now. Some patients that have various complex issues, I've seen stay almost 2 weeks. If it's easy to kind of keep them in the program and prevent issues with transition. So if Cleveland Clinic physicians think that you need more care longer, they'll keep you just like in a normal admission. But the average is 3.8 days, or 4 days roughly. Again, some of that data, it's a little skewed just in that some of those patients were already inpatient before they transferred versus coming out of the ED, but actually in the program it's 4 days.
And then does the Medicare Advantage plans ask for prior authorization for these services?
That's a specific question I can't answer. I don't know, Seth, if you know more about that, but they that is part of the screening that the hospital's doing. So that's not something that the patient would be involved in, but that may be part of the screening criteria.
What about meals over here?
Yes, we work, we have a couple of different options for this. We have a vendor who would provide meals, and we also use a service called Instacart. Instacart is it's an application where you can order things from like local grocery stores, and so our team would be talking to you about what you want, and if that's we can meet whatever dietary restrictions you have through one of our meal providers. They would show up with a bunch of I think they're pretty good, fairly complex kind of frozen meals, along with maybe some produce and fruit and things like that. But we can also do very specific things for you, like ordering just from a local grocery store. I don't know what the closest one would be here, but in this area we use like Heinen's or Giant Eagle, or there's various grocery store chains that we're able to just order through directly. Meijer, I think, is probably not super far from here. And so we would potentially, our scheduling team would check with the clinicians to make sure whatever diet restrictions you're on, and then we would order stuff essentially tailored to what your needs are or what your preferences are. Yes.
How would your program interface with the Stevens Care Center assisted living patients?
That's a good question. So for the assisted living patients, it really, because the intake point for our program is Cleveland Clinic Avon, if one of those patients were admitted to Cleveland Clinic Avon, they would have the opportunity, based on whatever screening criteria for their condition, to come back potentially, but be admitted here, and our clinicians would come in and take care of them. So it does, require that you're actually going to the hospital right now. Maybe in the future we're able to do some more direct kind of admissions. Right now everything goes out of Avon's ER or hospital.
I'll just add here, it would be essentially what Sean has presented. The clinicians that would come into the care center would coordinate a little bit more closely with the nursing staff and the team in the care center, whereas if an independent living resident from their cottage was admitted to this program in the hospital, there'd be more coordination with families and neighbors and whatnot.
Yep. Good question.
Yeah, you seem to be talking to a very unique population here. And I'm a geriatrician here, and I'm in Oberlin, and a lot of my patients are points west, points south, Wellington, all those places. Many of my patients are mildly cognitively impaired, live at home without a caregiver, and do not have cell phones or computers. So right away, they're basically not candidates for this kind of service.
It depends. Our setup, first from the technology side, doesn't have to connect with anything in the home. So it's not uncommon for us to have a patient that doesn't have internet, for instance. But in terms of being able to use it and cognitive impaired, they would have to have a caregiver there. We also, there's situations where we'll have sometimes 24/7 like home health aide ordered as part of the program who actually is there with them. So it's not unheard of for us to provide those services if it's a patient that is a candidate for other reasons. We can add those services into the home. The question really is, to me, what happens after discharge, for these patients? So if they can't manage, kind of that interaction with the program while they're there, we would be, almost more concerned about what happens after discharge with them. And depending on what they were admitted for, that's, that may be part of one of the factors that leads to the decision around intake. Certainly, that screening, that's a big part of what the APPs for Cleveland Clinic are doing, is looking at what your kind of resources are as a patient in home in terms of, caregivers or family members, people that are available. Ultimately, someone has to be able to go to the door and let us in, right? Like that's a big, just realistic issue.
I'm wondering if I call 911, I believe that they'll take you to the nearest hospital, but Avon is not the nearest hospital here. So what options would I have? What could I say? Take me to Avon? I mean, would that be possible or?
Yeah, so in the state of Ohio, there are some regulations primarily around trauma, actually, that dictate where an ambulance would have to take you with a 911 call. If it was a fall and they're concerned about various, trauma events, they may be forced to take you to the closest facility or potentially a specific like trauma facility. You are always allowed to ask to go to a facility of your preference. The fire department may or may not, agree to that, but would certainly, encourage you to do so, depending on your acuity. If they consider you to be unstable, if they're concerned about you, your status throughout that transport, they may kind of override it and say we can't go that far. But it is not, that is a common question because, even in areas that are more concentrated, the closer facility might only be closer by a mile, but they still get that pushback of, hey, they're right there. So I would just say, short answer, you can ask. If it's a trauma, if there are specific things involving your status at that time, they may be forced by their protocols in the state of Ohio to take you to the closest facility or a certain facility. But in general, for kind of a normal medical complaint, like if somebody had a UTI or something that's non-life-threatening in the moment, you certainly could ask.
I'm back to the food. If a person here is in the care center, they get food 3 times a day.
Yep.
Is it the right, unless it's a prescribed diet? And even here, we got meals available, may not, maybe the insurance will cover what our meal plan doesn't already cover, but.
Yeah, so, this comes from the language really in the CMS waiver, where to provide hospital alternative care or hospital at home, we had to provide like care, which means we have to at least offer it. So you guys are all in potentially in different circumstances than some where, getting food into the home is more of a challenge. And so we offer it. You're welcome to accept or decline. You can accept and see what we are able to order for you and if you like it or not. But certainly you're not forced to take the food that we provide at all. It's just a service that we have to provide through CMS. So they will. It's going to come to you as a question of, do you need assistance and support with meals? And if you do, then we can show you what the options are and order things for you. I was on a patient a couple days ago in our Denver market, and this came up, and they were, that was the question, and she was like, well, I have access to food, but maybe you could get me like these 2 things. And so it was like bananas and something else. So we just ordered that for her, right? So it's like we can do things like that too. So even if you don't need the full, meal, 3 meals a day, full support, you could say, well, I'm not gonna be able to leave to, go to a grocery store or something like that. I would like to get, these 2 or 3 things. We can order that.
Is this a duplication of services? If we're in the Stevens Care Center, we get lots of nursing care and lots of attention. The food is given to us. It's on our plan. I don't know how you get interwoven into what is offered here at Kendal.
Yeah, so if you were admitted to the hospital, you would not be here. You would be at Avon Hospital. This program is only for patients admitted to Avon Hospital. If you were admitted to Avon Hospital through this program, we could actually bring you back so that you could be in your home environment, but you're still admitted to Cleveland Clinic Avon Hospital for that time. So I know in a facility like this, it's a little bit different than just being at someone's house, but at the end of the day, that's where the duplication is. It's between that hospital system. And I know you're able to offer some of the same services here, but technically during those 3 days, you would be admitted to Avon.
We provide a very high level of service and care in the Stevens Care Center, but we cannot provide hospital level care on this campus. We're not regulated to do so. We're not paid to do so. We're not allowed to do so. And that's why these programs are popping up around the country in conjunction with hospitals who are able to provide this hospital level of care, but in a setting like your home where people would rather be. Yes, and you know there is overlap in terms of what it can be provided, but sort of the level of service that Sean's talking about and the amount of intervention is a much higher level than we're going to get here on campus. But also it's a 3, 4, 5, 7 day stay, and then there'll be a discharge back into the home setting.
But that's my question then. You spend 3 or 4 days with intensive people or virtual, however, in the home, and then once they're discharged, does everything leave, or is there some ongoing follow-up for these folks in the home?
Yeah, so when we discharge a patient, you know, the transitional care needs vary from patient to patient, but the virtual command center with Cleveland Clinic has, you know, social work and other team members that help with that transitional care planning, just like if you were in the normal hospital. So if you were in a hospital and you were actually on the 3rd or 4th floor of Avon, they would meet with you to discuss transitioning home on discharge. And so those same conversations happen here, where we try to determine what your needs are and what services you would need if you need to be transitioned to home health, or in the case if you're a resident here back into these services. The care team, the virtual command center team, is involved in those conversations just like a hospital would be. And so they would work to set that up for you, set up a follow-up with primary care if that's something that you needed. So it's relatively the same as if you spent those 3 or 4 days at Avon, where they have those team members who are actively working on transitional care planning.
And is this also cost effective?
It is. Part of the reason it's cost effective is because Avon didn't need to build, a new building or add floors on top of the hospital. Jacksonville, in Mayo Clinic in Jacksonville, where Seth and I worked for a while, they added like 4 floors on the top of the hospital, but they had budgeted for 6. But we actually, converted to, in real life, real dollars and cents, 2 of those floors didn't need to be built because we built them in the community. And so, that's part of the reason it's cost effective. Another part of the reason it's cost effective is that, the team is able to, the physician is still seeing essentially the same kind of panel of patients. We're able to run around and, the medics drive around and see patients. But because of that link with the virtual command center, we're able to see, pretty high ratios of like nurses to patients and things. So it does work out. It's relatively, I think, 25 to 30% cheaper is what the hospital looks at it, but it's also reduced readmission rates, has a financial impact as well. So from a health system perspective, it's effective both for patient experience and, just for the ability to grow within the community in terms of capacity without having to build new buildings.
I may have missed this. What I understand is that you have multiple Cleveland Clinic sites that are using dispatch. What I didn't hear, and maybe you said it, is whether other hospital systems are following your model. Yes.
So our company, primarily actually partners with Mayo Clinic and Kaiser, and we have lots of programs across the country with both of them. Cleveland Clinic partnered with us 3 years ago in Florida. Cleveland actually owns 5 hospitals in Florida, from Daytona essentially down to Fort Lauderdale, and so we have a very large program with them there. We also have a really big program with Mayo in Florida and in Wisconsin and Arizona and up into Rochester area. And so we have right now, I think 22 hospitals across the country that are doing this, and lots of hospitals do this on their own. So there's a massive program, for instance, with a hospital system called Atrium Health. They're really one of the true pioneers of this out of Charlotte. and they have, at any one given time, they might have 100 patients. So like multiple floors of a health system in the home environment, and they're now owned, in partnership with a company or a health system up in Chicago, and they're building a hospital home program there. And so you're seeing this really spread. Part of the reason for that was the waiver that we talked about for hospital at home that allows us to do this legally came from COVID, but it recently, in the last few months, got extended for 5 more years through CMS. Don't anticipate that it'll ever go away. Now it's very formalized, as part of healthcare. And so lots of health systems that, have thought about it over the last 3 years are starting to pick it up now. So there are tons of patients, different health systems across the country doing it without us. We've done about 95,000 patient admissions, really kind of since the beginning of COVID.
Then a follow-up question. Do you know if the university hospital system is considering following your model?
So I have some friends over there that I've talked to about this, and we would love to partner with them. They did actually, UH had a kind of small in-house hospital at home program for a little while, I think from like 2023, 2024. I don't think that's operational today, unfortunately, but I have talked to an old colleague of mine, is the CMO over at St. John's, and so I've had some discussions about what that would look like here. And now that we are here and we're operational here, it's a lot easier for us to partner with other local health systems, because the cost really is setting up the infrastructure of having the network in the community. And now that that's here, we'll be actively working towards trying to partner with other health systems. Absolutely. Yes, yeah. So internationally, and I meant to bring that up at the beginning of this. It's been in the U.S. since, I think I said 2012, 2015. There's been a couple of studies. Johns Hopkins started the first thing here in America, but internationally this is huge. In Europe, there's massive programs of home hospital, really, really popular in Australia and various European countries. And so, they're less strict in the regulatory setting than we are in terms of what's required. They don't have, even though they're a centralized payer, they don't have kind of the same regulatory structure through CMS that we do, but we're moving in the right direction. So really here in America, we're just playing catch up. This type of thing is very, very common in other parts of the world and in Canada. Yes, sir.
Does the CMS or the clinic have criteria for length of stay for any particular diagnosis? That is, if a person has a UTI and they're, after 5 days or whatever, they're not ready for discharge, are they considered for readmission or for a change of treatment, or how?
Yeah, so it follows the same, inpatient criteria that any other, they call it DRG or diagnosis, would follow. It's not different because it's hospital at home, but also I would just say that the care plan is specific to the patient. And so, if we hit that 3.8 day mark and you aren't better, we're not going to just kick you out. And that actually becomes a lot easier in home hospital because it's lower resource intensive, and beds are not in as high demand. And so I think, honestly, that the length of stay, it's more likely that we'll take patients who aren't incredibly acutely ill, but just not getting better as quickly as we would want. Those are great candidates for hospital at home, actually, because we're able to keep them a little bit longer and not have that kind of bed demand issue that the brick and mortar hospital would have. So short answer, it follows the same criteria, through CMS. Long answer, it's fairly flexible with what you need in the home. And then, the transitional planning will just depend on, the coordination between the virtual command center, physicians, and your primary care. These are great questions.
We have just a couple more topics to cover before 5 o'clock. Want to be mindful of everybody's time. Is there one last question for Sean?
Maybe afterwards, if anyone wants to go and see the technology,
Yeah.
step on the weight scale, welcome to do that afterwards. Sean can give you a little tour of that.
Sean, this has been very
Thank you
insightful.
all.
The future is
This is
here.
great.
Thank you. All right. So I'll have you unplug your laptop, please. Thank you. Next, we want to address a rumor we've heard. If we can. There we go. We've heard a rumor that if you're in assisted living in the Stevens Care Center, you must take Georgia Newman, our medical director, or Kristen Petsis, our nurse practitioner, is a primary care provider. That rumor is false. Have you heard that rumor? Yeah, see, it's common knowledge, isn't it? Yeah, but it's false. So we want to cover that. There are some reasons why that rumor is out there and alive, but Ohio law does protect the residents of assisted living communities and nursing homes they have the right of choice for a physician or a provider, as well as a pharmacist. As a resident of the Stevens Care Center, Ohio gives you the right to choose who prescribes your medical care and who writes orders for your medical care. You always have a choice, and you can always change your mind at any time. But there are stipulations to that, as always, right? Which are embedded in the regulations and the law. If you choose an on-campus doctor, such as our medical director who's in this room, or provider, such as Kristen, who is our full-time nurse practitioner, remember that Kristen is full-time here. She's here Monday through Friday, on call all the time. Georgia's here on Wednesdays, but she has an office here in Oberlin. And Georgia has had a 30-year history of answering her phone when it rings, 24/7. That our nursing staff know they can always get a hold of her immediately. One of them is always available 24/7. Actually, and most times, both of them are available 24/7. They kind of share weekends now and then, or holidays if one or other's out of town, but in general, both of them make themselves readily available 24/7. They can both access your medical record immediately and remotely. These are big pluses. Kristen can usually see you the same day when you need to see her, or the next business day, either in your room when you're in the Stevens Care Center or in the clinic. And she can also visit on behalf of Georgia before Georgia can get here, before you can get to her office. So between both of them, you have a lot of ready access. If you choose an off-campus doctor or provider, first of all, it has to be someone who's licensed in the state of Ohio. We cannot work with a physician who's not licensed in Ohio. We can work with you and your provider to make sure they meet state, federal, and facility rules. There are a lot of layers to that. And if your provider cannot meet these requirements or expectations, we'll work with you to look at other options respecting your preferences. The first is the most difficult and challenging, and that is our 5-bed skilled nursing facility. Medicare has a rule book for skilled nursing facilities that is not short of 958 pages. That is a lot of rules, and a lot of them apply directly to what a physician can and cannot do and what their timing needs to be in regards to visits and documentation. We require Kendal at Oberlin that resident be seen within the first 8 hours of admission. We think that's great medical care, that physician is seeing you in our skilled nursing facility within 2 days. Medicare then requires also that you be seen every 30 days for the first 90 days of your admission, which would be most cases in our skilled nursing facility since we treat it as short-term care. I have been a licensed nursing home administrator since 1991. It is very few physicians that are willing to live under the regulations of the Centers for Medicare and Medicare Services when it comes to nursing homes. There have been times where I've had a resident ask me, will you see if my physician will follow these rules set down by CMS? I've never had a physician say yes when I tell them the stipulations required. So I'm happy to make those phone calls, but remember, especially for most physicians today, it's not that physician who's answering that call, that question specifically, it's their employer, Cleveland Clinic, University Hospitals, Mercy, whomever that may be. Because what word do we always hear when it comes to physicians? Productivity. And when being able to come right here live and in person at Kendal takes away productivity time. So I'm not saying it's impossible. I'm just saying what the challenge is. Okay? Assisted living is a lot more flexible. Okay? And that's where we have a lot more opportunity, if you will. You have to recognize that if you are in our assisted living, which is the 74 other rooms in the Stevens Care Center, if you choose to have an outside physician, you lose the convenience of having that in-person physician here on campus, Georgia Newman, or on-campus nurse practitioner with Kristen Petsis. Staff will help you make appointments, and we can schedule transportation. And we've had residents that have done that. I'm looking at Kim Peters right now. Do we have one or none in the care center right now that has an outside physician? We don't have any right now, but we've had as many as 2 or 3. So it's not unheard of, and it can happen. But just remember that you're losing that convenience, and that's okay. Some folks, that's okay. It means making an appointment, and transportation does become more challenging, especially if you have limited mobility. It can happen. It's been done before. We can work that with you if that's your choice. Depending on your residential agreement, there may or may not be associated transportation charges, and if you need a companion to go with you, there would be charges for that companion to go with you. If you're in assisted living, Georgia Newman's still medical director, so she can be a default if necessary. If you're in assisted living and you do have that outside provider by your choice, Kristen's still available to treat you for acute conditions, but not chronic conditions. It's very specific. If it's something that's very acute, she can help you with that, but not for anything that's chronic. That needs to be your primary care provider. And the RN nurse manager will help keep your provider informed and coordinate care. Okay. That's a lot, isn't it, in a few minutes? So again, when you're in that 5-bed skilled nursing facility, that's extremely challenging to find another physician, and it would have to be a physician. It cannot be a nurse practitioner. It has to be a physician willing to come in person to see you during your stay. Possible, but I've not known of a doctor willing to do that who's not already on contract with that skilled nursing facility. Assisted living, a lot more flexibility. Just know that logistically, it becomes a little more challenging with transportation and scheduling of appointments, and you just wouldn't have ready access as you would with an on-campus provider. Does that make sense? Okay. All right. You want to say a word or two about Paige, Lori?
I wanted to add just a little piece of information to that, in that it also makes the staff, the team caring for you, have to have a tighter communication with that provider that you're seeing outside of here. So you may go to that visit, come back, they may not give us a note. So then we may have to contact that provider to see what that provider's ordering. Sometimes we can see the records in the electronic EMR, but that lends itself to a much tighter team and communication if that does take place, which we have done. Yep. I just wanted to remind people that Paige Yoder is our contracted registered dietitian that we have been having come to Kendal since January 1st. She is a lovely young woman. She comes every Monday. She's here from 8 to 4 o'clock. And she is in our health and wellness clinic seeing residents and staff. She has walk-in hours from 9:30 to 11:30 in the morning, which are consistent with our regular walk-in hours for other things, where you can walk in and say, I just want to talk to Paige about something, and you can see her. If you don't want to do that, you can call the health and wellness clinic and make a scheduled appointment to sit down with her also on Mondays when she's here. She does a lot of work with our hospitality and dining program right now. She also works closely with our Stevens Care Center staff and our dietary technician for the Stevens Care Center on dietary restrictions, food options, things of that nature. And then she's also doing presentations. She's done, I think, 3 so far we've got her scheduled. And if you didn't attend any of those, we have all of the materials. We can always give them to you. But the next one coming up is on June 1st, and it is called Feeding Your Brain, and it is in the green room from 12 to 1, and we will have handouts. And if you cannot attend, we always have the handouts available in the Health and Wellness Clinic. But please use her services. It's a free service. Even if it's just a one-time meeting or conversation you want to have with her, that's fine. If you want to meet and discuss, meal plans or diet plans or special dietary needs, or you're on a committee and you want to talk to her about that, we've done it all so far. And she welcomes all that. So please take advantage of her.
All right, thank you. And one other brief announcement, and this got announced this morning at the coffee hour. I don't know if you want to say anything specifically about it, computers, or the information's right there. So end-of-life training in partnership with Supporting Friends, Social Services, and Reserve Care. That's the name for what was formerly known as Hospice of the Western Reserve. It is Wednesday, May 20th, 9:30 until 10:45, though this morning with the announcement in coffee hour, she said until 11. So they'll be there till 11, so bump it in out 15 minutes in the green room. There's a sign-up sheet by the main mailboxes, and all are welcome. Okay. We covered a lot of things. One more thing when it comes to choice of physician in the Stevens Care Center. We're not trying to talk you out of it if you want an off-campus provider. We just want to make sure you're fully informed of the requirements and what the options are. All right, Q&A with Georgia. Georgia, come on up. And I see, Barbara, your hand's already up.
What does CMS mean?
What does CMS mean? CMS is an acronym for the Centers for Medicare and Medicaid Services. Medicare, that's the M. Yeah, and it's not CMMS. You would think it would because it's Medicare and Medicaid Services, but it's CMS. Yep. Very good. All right. Any questions for any of us or for our medical director, Georgia Newman, today? Or do you just want to come up and see the toys? Anything you want to add about physician coverage? No. You are and have been doing it for 33 years, yes. Yeah. Okay. All right. She's here if you need her. And Sean's available, so come on up and look at the gizmos.